Guys, I am here. Good evening. It is Cosi Talks live. We are live. Okay, here we go. So, for those of you watching the replay, go ahead and comment replay in the comments section. I do go back and check to see if there's any questions that are done after the show is closed down, because I know some of you are in different time zones or just not able to make the live show. I'm going to give you guys a minute or two to jump on board. In the meantime, I'm going to hopefully get the live stream going on Instagram. And as you can see, guys, I'm in a little bit of a different place than I'm normally at. It's just been such a really nice summer day here in Florida. And I decided I just wanted to keep the good vibes going and be streaming from my porch. And I don't know if you guys can hear the crickets, but they are going nuts right now. All right, guys, I see a couple of you jumping on board already. Go ahead and give me a shout out. Let me know who you are, where you're from, and what is in your cup. We got Eric coming in with Pepsi, Emily coming in from Central PA. She's got Mountain Dew tonight. I've got, because it's Florida, guys, so I'm doing the whole like water with electrolytes thing, just trying to keep up with the humidity here. All right, guys, don't be shy. Hey, Tom, I cannot wait to see what you've mailed me. I'm so excited about that. I've been checking my mailbox diligently. All right, let's see if this Instagram thing is deciding it wants to work. Always with Instagram, it takes a minute or two. So guys, I do apologize. Instagram just kind of like delays things just a little bit. So it always makes me jump through some more hoops to connect to Instagram. And hopefully I can get things going with this. All right, here we go. Who else do we got here tonight? We got Randy coming in from San Diego. All right, I see quite a few of you jumping on board this evening. Guys, I do have some questions that folks sent in this week and also through the texting, but feel free to go ahead and start putting your questions in the comment section as well. Eric, I cannot tell you how excited I am to go to Chattanooga this August. Like this year, I'm exploding with travel everywhere. It's been insane. So a couple of weeks back, I was in Fort Lauderdale for Hangers Encompass event, and I got to meet many of you there, and that was just what a wonderful event. Truly, as a clinician, it was just great to be able to jump in and help the amputees that attended get to try out really exciting new activities. So guys, if you've never been to a Hanger event, whether it's the BACA boot camp or an Encompass event, I would highly encourage you to go. It was a lot of fun, and I'm really hoping they'll bring me out for some more. Let's see. We got Audrey from Maine. We got Scott from West Virginia. Scott, I can't wait to meet you at the Amputee Coalition Conference, which is happening the first week of August in Atlanta. How many of you guys are going? Hey there, David. And then, yes, Eric, I will be going to Chattanooga, Tennessee. I will be giving my Cosi Talks 101 of talks at the Prosthetic and Orthotic Associates of Tennessee Clinic, otherwise known as POA. And if that sounds vaguely familiar, it's because they are my very loyal sponsors of the show. And Ronnie Dixon, the owner of POA in Tennessee, has been no stranger to the show, and he's been on several times before. All right, let's see if Instagram Instagram is deciding it wants to cooperate. Hallelujah. All right, now we got our Instagram folks on board, and we can officially get this party started. So for those of you joining me for the first time this evening, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist, now in hot, slightly sticky Tampa, Florida. I've been a PT for over 23 years, and my passion is working with the amputee community. Guys, you'll have to excuse me. I've been under the weather. Good heavens. For the past couple of days. And as you can see, I still have remnants of whatever bug I had for the past couple of days. So you'll have to excuse me. Hey, Andrea, there's my resident occupational therapist. Okay, this is not a good way to start the show. Hopefully it'll go a lot smoother. All right, guys. As you can see, I'm broadcasting from my porch this evening, and there's my husband. There we go. Say hi, Abby. He's trying to buy me some time as I cough up my lungs there. All right. Oh my gosh, seriously? Let's get to this first question, shall we? All right, Emily is asking, are there shrinkers with higher compression? I'm currently using a shrinker with 20 to 30 units of compression. But I think I've seen ones with 30 to 40 units of compression. I have lymphedema, and I'm not sure if my shrinker is providing enough compression. There are days where my prosthesis is harder to wear. Anybody got a cough drop? Seriously, man, this is crazy. Yes, Mark, do have a cold. I basically, in the last 3 weeks, I've been through 5 different airports. So I caught something traveling in one of those airports. Oh, yeah, Shirley, Bob is inside. You're right. He didn't want to ruin his tan. I love that. I love that. Okay. So guys, when it comes to your shrinker, right? Let's just talk about it, especially for those of you who are, new to being an amputee. The shrinker is a compression garment that you hopefully received in the first weeks after your amputation. Ideally, as soon as your surgeon can clear you to wear one, you want to wear one. And the whole purpose is exactly that. It's supposed to shrink. It's supposed to help compress your limb, to basically pump out the fluids out of your limb and to start helping with the shaping and the remolding of that limb and helping to get ready for prosthetic use. Mark, if you want to come and make me chicken soup, I will be your best friend forever. It's been a long time since someone has made me chicken soups. Being a mom of 4, I'm usually the one making the chicken soup. Anyway, so when it comes to shrinkers, guys, this is something that many folks will continue to wear for several months and sometimes up to several years after their surgery. Okay. The whole reason is because as we move throughout our day, our limb is going to expand and it's going to shrink throughout the day. And wearing a shrinker at nighttime, for those of you who are advanced prosthetic users, helps manage the volume of your residual limb. For those of you who are new to being amputees, your shrinker should be on at all times whenever you're not wearing your prosthesis. Okay. And I always like to clarify that because sometimes folks think that the shrinker goes on with the prosthesis. It does not. The shrinker is meant to be worn when the prosthesis is not on. And again, it's to help control the volume of that residual limb. Now, for someone, no worries, Tatiana, we're happy to have you here. And Tatiana, it was such a pleasure getting to meet you and Andre at the Empower Fest. And I'm so glad that you guys are here. And I have Andre's question right here. Okay, so with regards to the shrinker, there are some folks like Emily who have other underlying conditions that are going to really affect the shape and the size of their residual limb. So in Emily's case, she has lymphedema, meaning she has an excess of fluid that accumulates in her residual limb. And she's always going to be, working to help control that. So wearing the shrinker, yes, is something that she needs to be really on top of. When it comes to the compression gradients, Emily, I'll be very honest. I don't know the answer to that question. It would make sense to me that there are different gradients of compression. So the same way that when you have just general compression garments for other issues, like for lymphedema, that they have the different gradients, I would assume that with the shrinkers, there are also different gradients. How high of pressure that goes, I don't know. I know that your average shrinker is going to be about 15 millimeters of mercury of pressure. That's how they kind of measure it, the mmHg. You'll see that in the compression gradients. So for ones for 30 to 4 units, I mean, that's definitely a question for your prosthetist. And if I have any of my prosthetists here this evening, I would love to hear from them as well. Okay. And also, Emily, I know you're really on top of things, but when it comes to compression, guys, this is a Goldilocks scenario. Not too much, not too little, just right. Okay. If you apply too much compression, okay, then you're going to cause pain and a lot of discomfort. And in some cases, if you do have excess lymphedema, you can actually cause the fluid to back up into the heart. And those are in extreme cases, guys. Okay. So always when it comes to compression, guys, check with your clinical provider. Okay. If you're someone who has lymphedema, check with your lymphedema specialist to make sure that you're, using the right amount of compression, not too much, not too little. Woo, man. Whatever that bug was that I picked up, it sure was a good one. Hey, Jerry Ann from Arizona, drinking her caramel vanilla coffee. Awesome. Mark says, I wear my shrinker every night, and that's after 5 years. Guys, we've talked a lot about shrinkers. Some folks, they have very nice, stable limbs after a couple of years of amputation, and they don't necessarily need to wear a shrinker at night. I find, honestly, that the majority of my patients do wear their shrinkers at night. Again, it just facilitates getting into the prosthesis in the morning, and they don't have to do that hop, skip, jump into the prosthesis in the morning. You know what, guys? I'm going to go turn on my porch light. Oh, wait, I realized my porch light is out. That's why it's so dark out here. Woo! Kosi's a hot mess tonight, guys. Hot mess. All right, here we go with the next question from Andre. Andre says, I have questions about grafted skin burns, the healing process as it relates to general skin condition, wondering how long freshly grafted skin takes to heal before getting a prosthetic, if any of your patients are in that category. Yes. And guys, just as a FYI, part of my training throughout my 23 years of practice was in burn trauma. I worked several years in the burn trauma unit, spinal cord injury unit, traumatic brain injury unit. I've had experience in all sorts of different specialties of physical therapy, which for me, I'm so grateful for because it allows me to treat my amputee patients even better. And I tell my PT students this a lot. Amputee patients are not just amputees. Many of them are burn trauma victims, orthopedic trauma victims. They may have strokes. They may have a lot of other underlying conditions. So as a clinician, the more you can train yourself in the different specialties, the stronger you will be at treating your amputee patient. Okay. When it comes to patients who have burns or who have skin grafts on their residual limb, okay, protecting that skin is the number one thing, and it's so key. And I know, Andre, for you, you've already learned this right now. Once the skin grafts have been closed, okay, there's no open areas on the skin. Usually, the surgeon will clear the patient for wearing a prosthesis. Okay, every surgeon's a little bit different, but that's kind of the general rule. And guys, I apologize for it being so dark right now. I didn't really think this through very well as far as how quickly it would get dark over here. Okay. But as far as when you can start using a prosthesis, it's going to be the surgeon that clears you first. And usually it's when the skin is closed. The thing is, what do you do once you start wearing the prosthesis? And for someone like yourself, Andre, you have to be very, very careful with that skin. It involves keeping the skin healthy. Okay. Now, if you've had skin grafts, it means that you had at least third-degree burns, which means that you burned through your sweat glands and your oil glands. And that new skin that you have on does not have the ability to sweat or to produce its natural oils. Okay. So a lot of people who have grafted skin, they'll notice that the area of grafted skin tends to get dry, tends to get itchy. It tends to burn easier, and it tends to tear a little bit easier. It's just more sensitive all around. Okay. So skincare is absolute. I know that with my patients, my burn patients, I loved using cocoa butter. That for me was probably one of my favorite moisturizers for when the person was not wearing the prosthesis. Okay. When the person is wearing the prosthesis, I have other products I like to use, mainly because the cocoa butter, when you put a prosthesis on, it tends to make things very slippery. But when you're not wearing the prosthesis, I love cocoa butter for moisturizing. Okay. And again, check with your doctor. Okay. Check with your doctor. Everybody has a little bit different way of doing it. The next thing, when you start wearing your prosthesis, you need to be meticulous with your wearing schedule. And guys, this goes for whether you have burn grafts on your legs and skin grafts on your residual limb or not. But those of you with skin grafts, even more so. Okay. When it comes to a wearing schedule, I'm talking about just a few minutes at a time in the beginning. Okay. Once your prosthetist puts on your prosthesis, your socket with whatever socks you may need, you start the clock and you do it for about 5 minutes, standing, doing some weight shifting exercises, keeping it very, very simple and light. Then you take everything off and you look at your skin. Okay, you look to see if there's any redness. You look to see if there's any blister formation. You look to see if there's any skin tears happening. Okay. Let me see if I can turn on my phone light. Man, it is dark. That helped? I don't think that helped any. Ooh, now it's all spooky. We can tell ghost stories on Cosi Talks. Okay. Well, let me see if I can do that, if that helps any at all. Okay. Yeah, this is making me look really spooky, guys. I apologize. I'll have to bring lighting out here next time. Okay. So if you wear your prosthesis for a few minutes at a time when you have skin grafts, it allows your skin to accustom to getting used to wearing something like that. Okay. Now, at some point, especially if you have extensive skin grafts, you might experience a skin tear. Okay, it might happen. In fact, I can almost guarantee you at some point in your life as an amputee, you're going to have a skin tear. The important thing is to address it right away, okay, and to keep the prosthesis off while that is healing, whether it's a small one, hopefully it's just a small one, or a larger one, okay? And then Andre, I'm going to keep repeating a lot of these things over the course of the shows. I know I'm kind of throwing a lot of things at you right now. So if you have any other questions, you're more than welcome to keep asking them. But part of this is going to be protecting the skin. Okay. If you do experience any kind of skin tear or any kind of blistering or anything opening like that, the important thing is to figure out the why. Was it because you have friction in the socket? Was it because you have pressure point in the socket? What is the reasoning behind it? Okay. And again, your prosthetist and your physical therapist need to be working with you very closely, monitoring your skin, teaching you how to monitor your skin and how to do that wearing schedule and slowly progress your wearing time with your prosthesis. Ironically, a lot of folks who have extensive skin grafts on the residual limb, what takes them longer is not learning how to walk on the prosthesis, it's allowing time for their skin to acclimate to wearing a prosthesis. So they might actually learn the gait mechanics pretty quickly, but because of their skin, they have to take a little bit longer before they progress to wearing it full time. Okay, so I hope that answers some of your questions, guys. Don't be shy. For those of you who are new to the show, this show is for you. It's for you as an amputee, those of you who are clinicians for amputees, and those of you who are caregivers and family members. So please feel free to put your questions in the comments section. Hey there, Ilyas. Nice to see you. All right. Okay, here we go. Let's see. We got lots of folks jumping in on Instagram here. Let's see. D. Donahue was saying to wear two shrinkers together. You can wear an old worn out one on high volume days over the top of a newer one. That is a possibility. I've actually never thought of that. And I kind of like that idea because you are adding a little bit more compression. But again, as always, if you're adding more compression to your residual limb, you need to monitor yourself and make sure you're not adding too much compression because too much of a good thing is also, it's not good. It's not good either. Glad to see you though, David. We got you from South Carolina drinking green tea. We got a lot of folks coming in from Instagram. Guys, those of you who are on Instagram, please feel free to go ahead and put your questions in the comment section on Instagram. Thank you, T Page. We got a prosthetist there as well. I appreciate hearing you guys on here. All right, let's go back. What else we got? Let's see. I'm reading through some of these questions. Right. Sorry, guys. I'm scrolling through these questions, making sure I'm not missing anything. Okay. Next question here, if I can read it. Okay. So going back to, we're going to piggyback with this with the next burn question. It says, regarding sweating or lack thereof and heat regulation, do you have any tips or suggestions about how to regulate heat in the limb? I'm currently wearing an ACE bandage on my residual limb now, and my skin hates it. Yes. Okay, so guys, let's go back to what I mentioned about folks who have skin grafts on their residual limb. Okay, if you have a skin graft, okay, that means that the injury, the original injury, whether it was from burn or anything else, it went through your epidermis and your dermal layers, right? So it went through the layers that have your sweat glands and your sebaceous, your oil glands. So those are gone. Now, why is that important? Because if you don't have sweat glands or oil glands, it means that part of your skin is not producing sweat and it's not producing those natural oils that keep our skin, moist and protect our skin and prevent it from drying out. And then the skin graft that goes on top of that, okay, the purpose of that skin graft is to cover the area, right? To close off the area. But unfortunately, it does not have the sweat glands and oil glands to replace the ones that were injured. Okay. So the area of the skin graft is not going to sweat. Okay. And again, when I first worked in a burn trauma unit, it was really interesting to me, this concept. And yeah, I would see my patients who had extensive skin grafts and I would see them sweating profusely from their uninjured skin. And then when I looked at their skin graft, there was no sweat there. It's a very interesting phenomenon to observe that. And obviously what it means is that from the area of your body that is not injured, you're going to sweat more. Okay. The reason is because your body needs to cool itself down. That's why we sweat. We sweat to get rid of toxins in our body, and we sweat to regulate our body temperature. Okay. So if you're missing surface area because of those skin grafts to sweat from, the rest of your body is going to compensate and sweat more. Now, there are many of you that have also noticed this phenomena, even if you don't have skin grafts. Many of you have mentioned that since your amputation, you sweat more, whether it's you sweat more from your residual limb or you sweat more from the rest of your body. And again, it goes back to your body has less surface area to sweat from. Okay, so it's trying to make up for it. Okay, so again, when it comes to someone who has burn grafts or skin grafts on the residual limb, they just need to be extra careful, right, with taking care of their skin, making sure that it's moisturized properly, making sure that there's no shearing forces or any friction on that skin, whether it's from an ace wrap, whether it's from pulling on a liner, whether it's from pulling on a shrinker, all of these type of things. And then as far as regulating your body temperature, I personally have not found anything yet. There's no magical medication for that. A lot of that is allowing your body to get accustomed. And I have noticed again, I'll have to look at, I really should look up the literature on this, but just again, from my experience of working as a physical for burn patients, many of them, if they have less than 40% burn injuries, over the course of time, their body temperature starts to regulate a little bit. Some folks it does not because if they have extensive injuries throughout their entire body. But living here in Florida, again, for someone who lives in Florida and is experiencing this, they have to be very careful with their hydration, very careful about not overheating themselves and just kind of listening to their bodies with this. Okay, and over the course of time. Jerry, and then there's also other cases. So for example, and this would be more for, I would say, above the knee amputees. There are cases where if they are not able to use a traditional socket because of the burn and the grafts, excessive sweating, this is where the topic of osseointegration can be discussed. We've had folks from Integrum. They are the makers of the Oprah system for osseointegration. It's the only FDA-approved system currently here in the U.S. We've had them on the show several times, and actually a month ago we had a really great discussion on all the different types of osseointegration available out there. But one of the indications for osseointegration to be screened as a candidate is excessive grafting and excessive sweating that prevents the use of a traditional socket. Now, obviously, I'm talking in terms of above the knee amputees for the sake of those people living in the United States. But again, I always like to throw out information and then have y'all continue the research on your own. Steven says, I just turned in Why So Dark, drinking water, enjoying the show. Steven, I thought it'd be super cool to go live stream from my front porch because it was just a really nice summer evening and I really underestimated how quickly it was going to get dark. I think we're past the midsummer night. So it got dark a lot faster than I was expecting. Emily says, I don't sweat as much because of the spina bifida and the meds for my bladder, and I'd never make it in Florida. And guys, there are a lot of people, Florida humidity is no joke. I joke about it, but it's no joke. It is something that when I'm working with my amputees, especially in the summertime, I'm very conscious of when I'm outside with them. Especially if they have a thyroid condition or any other condition, because it can get extremely humid and extremely hot. So yes, it will affect the skin. It will affect your energy efficiency when you're walking. I know that when we had the Amputee Coalition National Conference in Orlando last year, and it was the first week of August, which is blazing hot and humid. I know that, there were several folks that were kind of struggling with that. They had to make sure to stay indoors for most of the time. Let's see what else we got. Sorry, guys. Let me go switch back over to Instagram because I keep forgetting to check and see you over there. All right. Okay, so here we go. All right, let me grab this next question. This next question also came from Emily. Emily, I think this is a question you submitted a couple of weeks back and I never got back to it. I'm sorry. Emily asked, I know you've talked about interviewing your prosthetist. How would you go about interviewing a physical therapist? I'm back in outpatient physical therapy, but the PT I was working with is PRN now. meaning they're part-time. Their new PT that is an amputee specialist is only there till the end of the month, and 2 other PTs don't specialize in working with amputees, as far as I know. I was looking forward to working with the same person I've worked with before, and that doesn't look like it's going to happen. So guys, I've done videos on this ad nauseum, and this is something I feel pretty strongly about in terms of knowing how to choose your prosthetist and how to choose your physical therapist. First of all, uh, it's understanding that you have a choice. And a lot of people don't understand that and don't know that. A lot of many amputees that I've spoken to over the years have said that when they had their amputation surgery, the next day they're in the hospital room and they're talking with their surgeon, and the surgeon introduces them to a prosthetist. Okay. And these prosthetists are obviously wonderful people, wonderful human beings. They want to be in there and as soon as possible to start introducing themselves, to start working with the patient, et cetera, et cetera, et cetera. But the patient's under the impression that that's the prosthetist that they are assigned to. And sometimes that's a wonderful thing. They get assigned to the right prosthetist from day one and it's happily ever after and it's wonderful. But sometimes it's not the best fit. And a lot of patients are left feeling almost sheepish because they're not sure that they can ask their surgeon to switch prosthetists. They're not sure how to go about doing it. So I'm here to tell you, you guys are in control of asking for your prosthetist or your physical therapist. Obviously, you might be restrained by some of the confines of your insurance, like maybe your insurance will only cover certain prosthetists or certain physical therapists. But within that framework, you have a choice. You have a choice. Okay. 9 out of 10 people who go into the profession of physical therapy and prosthetists, we're pretty good eggs. We're good human beings. We went into the field because we wanted to help people. We wanted to be healers, right? We're good people and we're good at what we're doing. But, there's the occasional bad apple, right? So how do you go about looking for a prosthetist or a physical therapist? Okay. Interview them. To me, that's like the best tool in your box right there to know if it's going to be a good fit for you or not. I even had one friend of mine, she's an above the knee amputee, and she knew about her amputation ahead of time. She had a cancer diagnosis. She knew she was going to lose her leg. So she had a few days to prepare. And I applaud her for what she did. She immediately looked up prosthetists in her area and she went and she introduced herself to her prosthetist before she even had her amputation surgery. And she basically introduced herself saying, "This is who I am now. I'm going to be a very different person next time you see me, but I want you to see who I am now. And I want to ask you questions." And I'm like, that's wonderful. How wonderful is that? Now, not everyone has the ability to do that. Not everyone has the ability to know they're going to have an amputation. Some are done in emergencies, scenarios. But you have the ability to talk to prosthetists. Okay. And the same goes for PTs. Okay. And just to ask them questions. What is their experience with working with amputees? Okay, with physical therapists, and ask them. Don't be shy about asking. Say, how many amputees do you see on average in your workload, in your caseload? How many have you seen in your career? Right? It could be like some of my colleagues that they saw a lot of amputees early on in their career, maybe not so much currently, but they still have all that knowledge and that experience to work with you. Okay. If they do not have experience working with amputees, are they open to learning? Are they open to developing a relationship with your prosthetist so that they can learn? Right? Because sometimes you might find yourself in an area that does not have any PTs with amputee experience, that they're not hanging the shingle out like I am saying, "Hey, I'm an amputee specialist. What do you do?" Okay. And some of you have successfully done this where you've gotten that physical therapist who's hungry and really wants to help you and wants to learn themselves. And you've connected them with your prosthetist and you've made a beautiful team right there. I say it all the time, guys. I had a wonderful PT mentor who taught me a lot, but so much of what I learned from componentry, prosthetic componentry, came from the prosthetist that was right down the hallway. And I learned so much from him. I still do. Okay. I'm still learning from all the prosthetists that I work with. Okay. And then with your physical therapist, ask them, are you going to be seen one-on-one with your physical therapist? Or are you going to be seen with several other patients? Okay. This is something I also talk a lot about on my show. Unfortunately, with the way our healthcare system works, okay, a lot of physical therapists are being kind of forced to see multiple patients at one time. Okay, because they work for hospitals or insurance-based clinics. My the clinic I have, it's not through insurance, so I see my patients one-on-one. Not every therapist has that ability. Okay, but you want to ask, are you going to be seeing me one-on-one, or am I going to be seen with multiple patients? The other thing, who is going to be providing your treatment? And here's another one that I like to really make sure you guys ask this question. Is it going to be the physical therapist? Is it going to be the physical therapist assistant? Or is it going to be the physical therapist tech? And there's a difference. Okay. PT or PTA, physical therapist or physical therapist assistant, we have licenses. We have clinical licenses. We went to a lot of schooling to get those clinical licenses. Physical therapy techs do not. Okay. And this is something that I keep an eye on. Sometimes if a physical therapy clinic has a really high volume of patients, they might have their PT techs administering treatment. That's a big no-no. Okay, so I'm just kind of giving you guys things to kind of, just keep in the back of your minds there. All right, so if you look inside the physical therapy clinic in the gym and you see that it's a bunch of physical therapy techs that are treating the patients and the physical therapist is off to one side typing notes in their laptop and just looking up every once in a while, that's not the clinic you want. All right, you want the clinic where you see the physical therapist putting their hands on patients and being with the patients. And unfortunately, guys, it's not even necessarily the PT's fault. A lot of times, like I said, it's our healthcare system that it's not perfect. It needs a lot of work, but that's some of the things you do. And it might take you some more time to find that clinic that's going to give you more personalized attention. Okay. All right, hang on. I've been talking a lot. Let me read some of these comments coming in. Mark asks, can you give this ignorant man an explanation of spina bifida? Mark, you are the least ignorant man I know. Okay, spina bifida is a spinal cord injury that is present in utero. So when the baby is developing inside the womb, part of the developmental process is for the spinal cord to close, not the spinal cord to close, for the sheath over the spinal cord to close. Sometimes it does not close all the way and it herniates out, right? So the spinal cord herniates out the back, meaning it pushes out of the back and it's not contained the way it's supposed to be contained. And that damages the spinal cord. So sometimes this is detected on ultrasound while the baby is developing in utero. Sometimes it's not discovered until the actual birth. And usually if you look up spina bifida image on baby, it'll look like a very dark spot on the lower back of the baby's spine, in the lumbar area. It can also be present with like a little hairy patch in that area to indicate that there's something there. So what has to be done is immediately after birth, they have to basically take the spinal cord that's been herniated, that's been pushed out, and put it back into place and secure it and stabilize it. They have done in the past, and this is something I need to look up and see where we are with this, where they've done some amazing surgeries in utero where they fix the spinal cord inside while the baby is still developing in the womb. And I saw a video once of the surgery and it was incredible. It was incredible. It was that surgery. I don't know if you guys have ever seen that video where the surgeon carefully, made the incision in the womb and the baby's hand came out and grabbed the surgeon's finger. It was kind of amazing. But these are very delicate procedures, very high risk procedures, and mom is put on bed rest until the birth process months later. So again, what happens with this is it's a spinal cord injury. So in the same way, in this very similar manner, when someone has a car accident and they are quadriplegic or a paraplegic, a spina bifida, someone who has spina bifida at birth experiences spinal cord injury from the level of the herniation below. Usually it's paraplegic. I don't think I've ever seen a spina bifida patient with cervical or quadriplegia. Usually it occurs in the lower thoracic and lumbar regions, and that's where you see the spinal cord injury. So over the course of their life, the person will function a lot as a paraplegic. The child will develop as a paraplegic. The severity of the injury, again, it's unique to every individual. If it was a small herniation, then the person will have less of a spinal cord injury, and they may even have some movement in their legs. And there are some people that it was so minimal that it wasn't even detected. It wasn't, I had one, and I'll never forget this case. It was actually the dean of admissions to the college I went to. She actually had spina bifida that was not detected until she herself was pregnant, and they discovered it. Crazy. So she went her entire life, very normal movement. I don't know how this happened. And they didn't discover it. And then you have the others that are complete spinal cord injuries, that they have no movement whatsoever. And you can see that the legs don't develop as normally, and they'll have more atrophy to the legs and everything in between. Everything in between. Okay. So that's kind of spina bifida there in a nutshell for you, Mark. It's been a while since I practiced pediatrics. Let's see. Emily says, I got discharged from physical therapy. They basically told my sister that she's my therapist now. I'm standing hold onto the railing of my wheelchair ramp, not ideal, and my insurance doesn't cover a wellness program at another facility. And again, guys, this is where it really does break my heart. Again, I'm grateful for the country that we live in and the healthcare that we have here, especially compared to other countries like the one I'm going to in July, Guatemala. That healthcare system is a mess, but it's far from perfect. To name the family members to treat your patients as their therapists, it's not ideal. It really isn't ideal, and I don't always have a solution for a situation like this. And I'm sorry, Emily, that you're having to go through this. The only thing I can think of is, don't stop fighting. See if your surgeon or your doctor will continue to write letters of medical necessity to show why you need to have continued therapy services. Also to show and demonstrate whatever progress that you've been making to prove that you are capable of improving. And that's why you need the continued therapy services. Emily, there's one person I can try to put you in touch with. She is an expert at getting prosthetic componentry approved by insurance. She's worked some serious magic for some of my viewers in the past. I don't know what her experience is with PT services, but we can certainly ask her. So Emily, send me an email. There goes that bug again. All right, guys, I'm still getting over this bug. Emily, send me an email and I'll see if I can put you in touch with this individual. And guys, that goes for all of you. Those of you who are new to watching this show, don't be shy. That's my email right there. Feel free to email me your questions. If I missed your questions tonight, or if you guys, I won't lie, personally and professionally, it's been a mayhem last 2 months. Mayhem. And there are still some things that I'm catching up on. If you have emailed me in the past 2 months and I have not gotten back to you, I do apologize. Please send me another email and say, hey, Cosi, I sent you an email. You haven't answered me. Can you please answer me? Because when I say it's been mayhem the past 2 months, I'm not lying. So anyways, let's keep going. Whew. Ronnie says, hi, Cosi, skin grafts can surely create many struggles with socket fits. Absolutely. Custom urethane liners can usually be the best choice of liner for maintaining a healthy limb and amputees with skin graft conditions. Thank you for saying that, Ronnie. I have forgotten to say that. Yes, I am a huge fan of custom polyurethane liners. They are more expensive because they're really custom made. But I've noticed that in my patients who have skin grafts, it really does make a difference. The way they're designed is they're kind of meant to shuttle pressure away from sensitive areas. So Andre, when you do go in for your socket fitting, I would kind of put that on the table and just be like, hey, can we skip the whole trying a silicone liner and just go straight to the polyurethane liner, especially if you're someone who has skin grafting all over their residual limb? That's something I would definitely put on the table. Emily asks, what are your thoughts on PTs that spend a session working with multiple patients at one time? That happens at my therapy center pretty regularly. I'm not a fan. And guys, I'll and again, it's as a therapist, it's really hard to navigate that situation. When I first started out as a physical therapist 25 years ago as a student and working, I noticed that in the outpatient physical therapy centers, we were being told you must see 3 to 6 patients an hour and make sure you don't mess it up because then you might actually hurt a patient. You know, that was basically the gist of it. And as a new student and as you're starting to treat patients and you realize the responsibility that you have to your patients and the responsibility that you have in providing good care, not creating an injury, God forbid, right? To do this with 3 to 6 patients at one time, it never made sense to me. And it scared me. I'm not going to lie, guys. It scared me as a young therapist because I'm sitting there going, what if I miss something because I'm working with one patient, this other patient's over here doing something else. And if I miss something, or even if I have the PT tech who's supposed to be helping me, if they don't report something back to me, I'm responsible for that patient. So it shaped my career, guys. I'm not going to lie. It shaped my career. This is a huge reason why I went to practice in acute care. This is why I went to work in ICUs, trauma centers, because in those settings, the physical therapist works one-on-one with the patient. There's no working with multiple patients at the same time. So that shaped my career. And then as I became a more experienced therapist, I started realizing I was like, the problem's not with me. I'm a good therapist. I'm a good clinician, right? The problem is with our system. When you go to your doctor's office, yeah, your doctor might, if they're busy doctors, they may only spend 10 minutes with you, but it's 10 minutes just with you, right? They don't have another patient sitting next to you that they're going back and forth between you and the other patient, right? If a surgeon is operating, they're not running, or they're not supposed to be running back and forth between multiple operating rooms. They're supposed to be focused on the patient that's in front of them. So why is it that the physical therapist can't do the same? Right? And it is insurance. It is insurance. So to pay the bills and to pay the therapist and to keep the lights on in a physical therapy clinic in a hospital or in a clinic setting, it means PTs have to see multiple patients. Okay. Now, that being said, as a physical therapist, you do have the ability to speak up. Okay. And again, you don't run in this too often, but I have seen it. In the 25 years I've been in, working as a student, between student and professional clinician, I have seen certain clinics where the supervisors will say, you must meet this quota. And in order to do that, you have to utilize the techs and the techs providing treatment. As a physical therapist, you have the ability to stand up and say that goes against our Practice Act to use techs in that manner. Okay. It puts the PT in a very, very awkward position. And I know that if there's any therapists listening on right now, they're probably going, yep, yep, yep. Okay. So what happens a lot is a lot of physical therapists will either go and open up their own clinics like I did, so that I get to call the shots on how my clinic runs. Some of them have left the profession altogether. They got burned out because they were seeing so many patients at one time, and it was ridiculous, and they got burned out. So, and again, a lot of it also depends on the kind of patients you're seeing. So for example, if I have 2 patients that have just had total knee replacements and I put them on gym mats, one next to the other, can I provide good quality treatment to both of those patients at the same time? Yes. Why? Because total knee replacement patients, it's a fairly simple protocol. Okay. And if if I'm right there with the 2 of them, I can handle 2 patients at one time and provide good care. Amputee patients, no. No. And those of you who have been my patients, those of you who have come to my clinic, how many minutes did I spend away from you during our 1-hour session? 0. 0. When I'm working with my amputee patients, I am with them the entire time. My hands are on them, making them do whatever it is that they need to do for most of that time as well. That's it. It's not a perfect system, guys, and I don't claim to have a solution for it. I know what I've done throughout my years as a therapist to try to avoid those situations where I would have to see way too many patients at one time, and I've been able to successfully avoid that situation. But yeah, I sympathize for my fellow clinicians who have been put into those situations. Let's see. Yeah, and the consistency, as far as having a rotating schedule of physical therapists and physical therapist assistants, again, uh, you have clinics that are really, really busy, but even clinics that are really, really busy, if they are being run well, they will try their best to have consistency among the therapists, to have continuity. We call it continuity of care. Some clinics do it better than others. Hey there, Kathy. Let's see. Steven says it's still daylight in Michigan. I've lost 55 pounds since my leg was fitted. I plan on losing more. When should I contact my prosthetist for an adjustment? Congratulations, Steven. That's amazing. So this is a question I get a lot on my show, and I always love to answer this question. All right. The textbook will tell you that when you reach 15 ply in your socket, you're wearing 15 ply socks, that's the time to change your socket. The Cosi answer, and one that's echoed by many of my fellow clinicians, is when you start to lose connection with your socket. Okay, and here's what I mean. There are some of my folks out there that when they wear 8 ply, they're going bonkers, right? They can't feel their socket. They feel like they've lost connection with it. They're starting to not feel as stable in their socket. And they're, because you have all that thick layer of socks between your limb, and the socket. And it throws off your proprioception and balance. And then there are some people that throughout the day, they're increasing their socks. So by the end of the day, they're wearing 15 ply. The next day they wake up and they're back to 1 ply. And that's how their day goes. And that's stable for them. That works for them. They have no problems with it. That's how their leg works. And I say, bravo to them. Okay. So, Stephen, I would say when you start to feel like you're feeling a little wibbly wobbly in that socket, it's time to go in and get an adjustment. It's time to go in and get an adjustment. And don't be shy about it, guys. Don't feel bad about saying, I know I'm only wearing 5, 6, 7 ply, but I'm not feeling right in the socket. Don't feel bad about saying that. Okay. I have a lot of patients that if they have to wear more than 1 ply, they don't feel right in their socket. And I don't blame them. I don't blame them. If I had to wear a socket, I'd want the least amount of socks there as possible. Okay, Stephen, this is another thing I like to also, one second. Also where I like to bring up the option of an adjustable socket. Click Medical, one of my favorites out there with their RevoFit and their Revo Surface systems. Okay. So this basically is exactly that. They have that great click reel that's on the socket. And of course, it's all inside. I didn't have it with me. You click it and it adjusts the socket. It expands it or it contracts the socket. So for those of you throughout the day who have a lot of volume fluctuations, this is a great way to adjust that volume without having to wear a lot of socks. Okay. And Stephen, with the Revo Surface, so for example, Stephen, let's say you have a socket that you have right now and you like how it fits and it's doing great for you. It's just shrinking a lot. One of the options your prosthetist has is to order the Revo Surface kit. Let me write that down. Revo Surface kit. Okay. They can order the Revo Surface kit and then put that adjustability onto your existing socket, and it buys you a little bit more time. Okay. So that's just something to think about right there. ¿Qué más? ¿Qué más? ¿Qué más? Woo! Lots of comments. So Emily says that her spina bifida was not detected on ultrasound in 1988, that hers was in the lumbar area. And again, it's been a minute. I haven't worked in pediatrics, guys, since the beginning of my career. So I'm not up to date on as to how soon they're detecting spina bifida. But Mark, you're awesome, man. Okay. So Audrey says, I'm a left above the knee, and as of March 2023, I also have CRPS and my right knee is shot. After a year of attempting to wear a socket or use a prosthetic, we've decided to stop all these attempts, and I'm resorting to life in a wheelchair. No osteo for me because of CRPS. I'm good with it, but do PTs work with amps and wheelchairs? Yes, we do, Audrey. Yes. There's a lot of things. And again, I'm sorry that you've had to go through everything. But yes, you can become really independent with your mobility with a wheelchair. It all starts, first of all, by getting yourself a really great wheelchair. And again, this is where I would urge you definitely to work with a physical therapist, because a lot of times the physical therapist is the one in charge of writing the prescription for a wheelchair. Let me backtrack. The surgeon or the doctor is the one who signs the prescription. The physical therapist is the one who really writes all the details out about what's involved in that wheelchair prescription. Okay. And again, harking back to my days of working in spinal cord injury unit, to order a wheelchair, it was like pages of options. And it was, whoo, right? Even down to the kind of grip that you would put on the wheelchair wheels so that the person could more easily wheel it, right? The kind of like textured surface on the wheelchair grip. Crazy stuff like that, right? So there's a lot of things that can be done to the wheelchair itself to make it more maneuverable, to make it more accessible within your community and within your home. Okay. So I would definitely connect with a physical therapist who has that experience. Your spinal cord injury therapist, those are probably the best ones to help you out with something like that. And then, Audrey, I would continue your physical therapy with a spinal cord injury therapist. Why? Because they're going to be the ones who are the best and experienced at treating folks who use wheelchair as their primary source of mobility. Okay. The spinal cord injury center that I worked at in Miami, we had an outpatient center just for our spinal cord injury patients. And the focus was on upper body strength and whatever core strength the person had available, which in your case, you will have core strength. And that's what you're going to want to focus on to make sure that you stay strong in your wheelchair, to make sure that you don't get any shoulder injuries, and that you have the energy that you need every day to get around in the wheelchair. Okay. So I would say maximize your mobility with that and definitely connect with a physical therapist. Van Gregory, there's my grasshopper, man. I got to tell you, Van Gregory, I am still looking back on the pictures and videos of us at Empower Fest, and it is still making me smile. There were some great pictures, by the way. Guys, those of you who went to Empower Fest, I think Hanger sent out a link with all the photos of the event that you can download. So Van Gregory, there's some really good ones of you and I doing the run training. I'm going to post those. There's like so much fun. All right, Marianne, there you are. Jerry Ann, if I did not answer your question, darling, can you please post it right now? Post it for me. Linda says, find another clinician that gives you the attention you deserve. Yep. Kevin, oh my goodness. He says, time flies. 2 years ago, you were about to head out with Range of Motion Project, 2 years of memory on Facebook. Yes, and I'm actually headed back out again with Romp. Guys, now that I have a lot of you on board this evening, here's where I need my Cosi request, okay? So for those of you who've never heard of the Range of Motion Project, also known as Romp, by their acronym. It is a phenomenal nonprofit organization. They've been open now for 19 years. They have a clinic in Guatemala and they have a clinic in Quito in Ecuador, right? And it's an amputee clinic. And it's David Kruppa is his name. I haven't met him yet. I'm actually going to get to meet him on this trip. He's usually in Ecuador. He's going to be in Guatemala. So he and one of his colleagues founded this organization to provide prosthetic care for amputees in these two international cities. So they regularly host visiting prosthetists and therapists from countries, mainly from the US, to go and help work at that clinic. So in 2022, I was able to go with my two daughters, and we spent a week and a half working at the clinic in Zacapa in Guatemala, and it was the most amazing experience. If those of you want to like go through my Instagram in July 2022, you'll see all the pictures and videos. So once again, I will be going this summer, and I'm so excited about that. I'm so excited to hopefully see some of the people that I saw in 2022 and just see where they've come along, and to see new people and to get to meet the people at Romp, and they have a new clinic and all that kind of fun stuff. So here is my ask. I know I'm very long-winded to get to the point. If you guys have any components, okay, and you're looking to get rid of components, or you have that closet that everybody has in the back of their house that's full of stuff, right? And there's any good prosthetic componentry there, please let me know. We are accepting prosthetic feet, prosthetic knees, unused liners, unused shrinkers. Unfortunately, we cannot accept sockets because that's kind of customized to every person. But if you have any of these componentry devices and they are in good working condition, please let me know. I will provide you with my mailing address so that you can send them to me, and I will take them to Guatemala for somebody who will be able to use them. Unfortunately, here in the States, because of federal regulations, we're not allowed to recycle our prosthetic componentry for our patients in the United States, which makes no sense to me. But we can use them in Guatemala. So if you have any of this componentry, guys, please reach out, let me know, and we can work something out and have you send it to me. So, and I really hope that that was a cat that was walking by. Okay. Okay, so Sean says, I had an aluminum plate break on my leg at work. Every time I would take a step, my foot would turn completely inward. I have a new prosthetist that Dr. Weiss at Brooks recommended to me because of my unique condition. So I go to Hanger Clinic and the plate got replaced with a titanium plate, and my prosthetist found that my leg was 5 inches too long. Oh my gosh. First of all, I got to give a shout out to my boy, Howie Weiss, Dr. Howie Weiss over at Brooks Rehab, and Steve Pompilio, physical therapist. I got to meet the two of them at Empower Fest. If you guys are anywhere near the Jacksonville, Florida area, you need to go see these guys. They are phenomenal, amazing human beings and clinicians. So Sean, you are in the best of hands there. And I am so glad that Dr. Weiss, that you're in the hands of Dr. Weiss, because I know he's going to take wonderful, wonderful care of you. Let's see. Dawn says, hey, Cosi, I finally got my first check socket fitting and did not do a good job. I took steps right away. No challenge, but poor fit. Bottomed out after 2 minutes, and now I have a blister. Oh, Dawn says, little mad at my prosthetist and he didn't catch it right away. Dawn, I'm so sorry. I know you've worked so hard and you've been waiting a long time for this. Don't get discouraged. It's happened. It happens. And I mentioned earlier in this show, I don't know if you were here earlier on, at some point in your life as an amputee, you're going to get a blister, you're going to get a skin tear at some point, and it's knowing how to handle it. You learned that lesson right away. Bottoming out is definitely, the first enemy, public enemy number one of an amputee using a prosthetic socket. Boy, I can't talk right now. Okay. Bottoming out is exactly that, guys. When your residual limb hits the bottom of your socket. And contrary to what you might think, it's not supposed to do that. Okay. It's supposed to kind of be kissing the bottom of the socket, okay? Just ever so gently. It's not supposed to be actually putting pressure into the bottom of the socket, because then you get the skin breakdown. Dawn, please don't beat yourself up. It's basically, let's get that blister healed, which means not wearing your socket. I know, that stinks. Letting it completely heal. Once it's healed, Dawn, I need you to protect that new skin, okay? So when you put that prosthetic back on, have the prosthetist there, and that prosthetist should be determining, okay, now we really got to watch you like a hawk, because now we know what can happen, and it happens very quickly. You might just start off by doing weight shifting exercises, okay? And again, Dawn, I know you're a very active individual. So in your particular case, you might be one of those folks where your progress is being limited by your skin, not necessarily your ability to walk. Okay. For the majority of patients that I've worked with, an amputee, by the time they get enough gait mechanics and the ability to walk and balance, the skin has had a chance to kind of acclimate and catch up. There are other folks that they just have a more natural ability to learn how to walk. So they'll learn how to walk fast, but their skin can't keep up with them. Okay. It's not to say it won't happen. It just means you have to give a little bit more time to that skin. So again, for yourself, Dawn, definitely that wearing schedule and sticking to it. Oh, let's see. Kimberly, glad you're here, babe. All right. Rolo. Oh, it's Earl from California. Question: 3 months into first AK prosthetic, I keep getting blisters at the end of my limb. Why? Oh, today is the show for people getting blisters on their residual limbs. Earl, first question I would ask is, are you bottoming out like Mr. Don did? If you're bottoming it out and that socket, you're going to get blisters, especially if it's at the bottom of your limb. Okay. And again, this is something you need to take it back to your prosthetist and ask them, am I bottoming out? Some folks can feel it, right? They can feel the bottom of their limb hitting the bottom of their socket, and they can feel it right away. Many folks cannot, because they have damage to the end of their residual limb, and the sensation there for them is not normal. So they may not feel it and keep getting blisters. Earl, definitely take it back to your prosthetist. It could be that perhaps you are not using the right amount of socks and means you're not getting the right fit in your socket. And your prosthetist needs to help you adjust that. Also, Earl, hopefully you're working with a physical therapist. Oh, I hope you are. And they should also be helping you with this, with your wearing schedule and helping you adjust the fit of your socket to make sure you're not blistering. If they're checking the fit of your socket and you're wearing the right amount of socks, then your prosthetist needs to take a deeper look into that socket to see what is going on. Okay. But yeah, no bueno. Sean says, I wake up, use no socks, but during the day, I end up wearing 10 plus ply. Yeah. And Sean, that can be very normal for a lot of folks. I'm actually going to be putting out, wait, did I put out our video? Okay, guys, if you go to my YouTube channel, I believe I have a video on limb volume management. Okay. And in it, I talk about how in the first 2 years after amputation, your limb volume is going to be up and down and up and down, right? But after those 2 years, your limb hopefully stabilizes. But what that means is something different for everybody. For the very few lucky unicorns, a stable limb means that it doesn't change very much. It might change over the course of their lifetime, but it's very gradual changes and doesn't really make an impact much on their daily life. Again, those people are like few and far between. For the rest of us humans, right, our limbs and our bodies are constantly changing. But stable limb might mean that it's predictable. So Sean, in your case, you know that when you wake up, you don't wear socks. By the end of the day, you're wearing 10 socks again. You go to bed, you start the process all over again, right? And some of you might be like Sean, where you start with no socks and you have some socks by the end of the day, restart the cycle again. And then you also know, okay, today I hit the salt and vinegar potato chips, so I know I'm not going to be wearing as many socks. Or I sweat a whole bunch today because I went on a 6-mile run with my crazy physical therapist, Cosi. So I know my limb is going to be a lot smaller and I'm going to need more socks. That's what it means to have a stable limb, meaning it's predictable and you know how to manage it. Okay. Again, Sean, if you're one of those folks that's just like 10 ply by the end of the day, and that's a lot. I wouldn't be comfortable, I don't think, in a 10 ply, right? This is where something like a Revo Fit or a Revo Surface or an adjustable socket would be a great option for you. Okay. And I can speak for at least the Revo Fit and the Revo Surface. It can adjust up to 10 ply, right? So that's pretty significant. Ronnie says, exactly, 7 to 10 ply max, then you really start losing the loading aspects of your socket to provide you to the proper fit and function of your prosthesis. Yep. There you go. Oh, Van Gregory, you're awesome, man. Hey, Benny. Let's see. Sorry, now we're getting mosquitoes. Okay, Jerry Ann says, my stump is still healing. It's pink, like on the incision when I should get fitted. What is it not okay to do? Okay. So Jerry Ann, if you're talking about when to wear a socket, if the incision is completely closed, there's no open areas, then it's going to take some time for that scar to heal. And I'm just trying to think in my head how can I explain this. Okay, so and again, this goes back to my burn trauma days. Pale, planar, and pliable, red, rigid, raised. Okay, so I had to remember my mnemonics. When you're looking at a scar or a closed incision, it's considered to be an immature scar if it's the 3 R's: red, rigid, raised. Okay. It's considered to be a mature scar if it has the 3 P's: pale, planar, meaning flat, and pliable. Okay. So Jerry Ann, if your incision is still pink, we're going to call that a little bit more on the red side. So we're going to say that your incision is still immature. Okay. And over the course of time, usually 1 to 2 years, the scar will become mature. It's going to pale out. Okay. It's going to be more flat, that when you run your fingers over it, there's flat. It's not raised. It's not, and then more pliable, meaning it moves around. It's not stuck. It's not rigid. Okay. So while it's still in that healing phase, is the maturing phase, like it is right now, you just have to watch it very carefully. Okay. That means, again, going back to wearing schedules. If you're starting to use a prosthesis, not to get too aggressive with how long you wear your prosthesis because you can develop a blister in that pink area. Okay. If you do happen to develop a blister or skin opening, then you definitely want to keep everything off and make sure it heals properly. Okay. And then making sure that you're avoiding friction in that area, especially in that scar area. So your socket fit has to be pristine. And this is something that your prosthetist is going to be checking up on, and also your physical therapist. Okay. Making sure that you're not having any friction in that area, making sure the liner fits properly, making sure the socket fits properly to prevent that friction from happening. Okay. Mark, what do you mean by website? Which website are you referring to? Emily asked, do I know of any place that takes old wheelchairs? I have several just sitting around. That's a great question, Emily. I do not. But I would encourage you just to Google something like wheelchair donations, because I know when it comes to wheelchairs, I would do that. Google wheelchair donations. Uh, Sean, man, I am glad to hear that. Okay, let's see. Oh, whoops. Thanks, Tom. Sean says, I am now mentoring for Brooks, helping other amputees. Man, Sean, I am a little bit jealous because I would love to just work with Dr. Weiss and Steve all day long. We had way too good of a time at EmpowerFest working with people. Hey there, Coleman. Good to see you. All right, guys. I think I am done for this evening. I am getting eaten alive by mosquitoes, and I think I need to rethink this whole streaming from the porch thing, but it was kind of cool. Just fun to try this out. All right, guys. Next week, what's next week? Next week is the 4th of July week. I will be here because it'll be July 3rd. So I will be broadcasting to you guys next Wednesday. Send me your questions, guys. This show is for you. I can't do this show if I don't have any questions. So here's once again my email address. If I did not get to your question tonight, I do apologize. And like I said, guys, the last 2 months have been crazy insane for me. So if you have emailed me and I haven't gotten back to you, please send me another friendly nudge and say, hey, Cosi, here's my question. Please be sure to answer it. And I will be doing that. I'm catching up with everything this week. All right, guys, as usual, thank you for letting me be a part of your lives this evening. I will see you next week. Same bad time, same bad channel. Bye, guys, and God bless.